So the topic I have been given by Ashish is acute stroke and stroke mimics. I will talk about management perspectives. Primarily, I will focus on the current national guidelines for acute stroke management. So just to share the impact of the disease, in a typical large vessel intracranial occlusion, with every passing minute, one loses 1.9 million neurons and almost 14 billion synapses. So the time lost is brain lost. So every minute passing by is critical for the patients. I'll start with a case. Imagine that you are the resident doctor on call and it's your clocking shift. You've been asked by the ED to see this patient. He's a 64-year-old man brought in by the ambulance after being found confused in the town center at around 4 o'clock. You're seeing him in the emergency department at around 7:30 in the evening. He's lying in the couch. He's drowsy, but arousable. Drowsy in the sense he keeps his eyes shut, and you have to give him painful stimulus to awaken. You can't hold a conversation with him. He just doesn't give you any verbal response to your commands. His GCS is E3, V2, M5. You can notice a mild right facial droop. You've scored his NHS score as 9. Those who don't know about NHS, I will be talking about it in the coming slides. So from the audience, what would be your next step?
So we need urgent CT scan to rule out a hemorrhage. We need to contact the stroke team because he's within the thrombolysis window.
Brilliant. Before you ask for CT, anything else you want to see in the examination?
Any airway concerns, swallow concerns?
Great.
I'm not sure. Anything else?
So the most important, blood sugar.
Oh,
so yeah. You shouldn't have a patient who's got acute hypoglycemia, for example. You also need to know how the blood pressure is, because if you were to do an active treatment for an acute stroke, be it ischemic or hemorrhagic, high blood pressure, especially a blood pressure beyond 185 by 110, will become a contraindication to do the thrombolysis. And of course, you don't want septic, hypotensive patient in the ED coming in with a neurological presentation. And the oxygen saturation, so acute type 1 and type 2 respiratory failure will not have a neurologically intact. They will have higher mental dysfunction if they have acute hypoxia or acute CO2 retention. So the vital information is important. So once you've received that, then yes, go for an urgent CT head. And based on if you're part of the stroke team, what would you do? What do you think your treatment options would be at this juncture? So this patient is in a district general hospital. And most of the stroke-related lesions are made through SCT angiogram and plain CT head. So in this patient, plain CT head was normal and CT angiogram was also normal. And because he had a right-sided neurological impairment with an NHS score of 9, including the right facial droop, he was given intravenous thrombolysis through alteplase. After an hour of alteplase infusion finishing, patient had generalized tonic-clonic seizures. If you're the resident doctor who is on call and he's called by the nursing team that patient is having seizures, what would be your next step? So he's been thrombolized, it's an hour gone, and now he's having generalized tonic-clonic seizures. Anybody, what would be your response to the bleep?
So we need to terminate we need to time the seizure activity first, and then, if appropriate, terminate with benzodiazepines, and then consider a repeat CT head to see if there's any hemorrhagic changes.
Excellent. So you'll give him at least 3 milligram flurazepam. That should terminate the seizures. If not, then you'll be loading him with levetiracetam in the preference. And as soon as you've got the airway and the seizure controlled and airway secure, you will get a repeat CT head. And repeat CT head shows the same, no new findings, plain CT head to put it again as normal. So this patient essentially had presented to emergency department in post-ictal state. He had seizures and unwitnessed seizures in the community. And the confirmation came through when he had witnessed seizures with a normal-looking plain CT head. So that's one of the part of my discussion today, which is to talk about stroke mimics. But let's stay focused on acute stroke for now. So this patient who unfortunately was thrombolized, although he didn't come to a harm, but his diagnosis wasn't acute stroke. Equally, you do need a plain CT head to be able to decide about thrombolysis. In the sense, acute stroke doesn't always appear in the plain CT head scan. If an acute stroke is starting to appear in the plain CT head through a hypodense area in the CT scan, then often the time onset is more than 4 hours. And beyond 4.5 hours, you need further more sophisticated imagings to be able to make it is a non-safe thrombolysis, i.e. you will need CT or MR perfusion scan. But nowadays, you are meant to do both CT head and CT angiogram from aortic arch till circle of Willis before making a decision or a judgment on what treatment you will offer. If there is no contraindication to thrombolysis, then of course you will start with thrombolysis, and you will have had a CT angiogram to allow you to think whether there is a large vessel intracranial occlusion or not. If there is a large vessel intracranial occlusion, then those patients would be considered for mechanical thrombectomy. So this patient had left ICA critical stenosis, as you can see in his angiogram. It was a ulcerated plaque just above the carotid bifurcation. And that ulcerated plaque had invited a primary thrombus formation, which then got dislodged into the patient's left proximal MCA. So this patient was started on thrombolysis, and then he was transferred through a blue light ambulance to the local comprehensive stroke center, where he underwent mechanical thrombectomy. But that's for the specialist team to take over. For you as a resident on call who is on the clocking shift, there are certain important basic things I would want all of you to remember when you are called to see somebody who's got an acute neurological presentation, especially in the context of stroke. So the timing or the clock in acute ischemic stroke starts from the point when they were last well. It doesn't start from the point when they were found to have a neurological impairment. It starts from the point when they were last seen well. And the reason being is often patients with acute stroke, especially if they have a dominant hemispheric event, they lose their language. So they're not able to tell when the thing started. But there will often be a direct or indirect account of who had seen them last well, if that makes sense. NIH scoring is the core part of acute stroke assessment. It is a 0 to 41 point scale. Higher the score, more severe is the stroke. Those of you who are interested in getting a training in NIH scoring can visit this website, nhsstrokescale.org. It's a beautiful website which shows a video of NIH assessment. And if you take their video assessment test, then they give you a certificate of being trained in NIH scoring. As I said earlier, always check their blood pressure, sugar, and temperature, along with the oxygen levels, to make sure that you're not missing an obvious illness along with that acute neurological presentation. Get a green, preferably cannula, into the right proximal forearm, which is the favored site to have a good CT angiogram for patients. Always ask for CT angiogram from aortic arch till circle of Willis. Some of you end up putting a request of intracranial CT angiogram, which doesn't help us fully because we are interested in knowing what's happening in the aortic arch and what's happening at the origin of the great vessels. Out in the community, that I'm sure everybody would have seen the FAST advertisement on television. So FAST stands for face, arm, speech, and time. I'm hoping all of you are familiar with it. Still till date, quite a few emergency departments do the Rosier score, which is very similar to FAST score. It's just a matter of getting familiarized to it. Both help you in getting a differential diagnosis of stroke on the floor. As you can see, it does preclude patients with transient loss of consciousness or seizures out of the equation of stroke, which is often the case in majority of the stroke patients. Having said that, some of them can come with impaired consciousness, especially the ones who have somewhat late presentation and rising middle cerebral artery, a large stroke causing rise in intracranial pressure. They will have low GCS, or patients who have had a brainstem stroke, especially the midbrain involvement, that will cause impaired level of consciousness. Some patients with cortical ischemic stroke or lobar hemorrhages can present with seizures. So never say never, but in majority of the cases, there will be other causes of loss of consciousness and seizure activity. So if you're covering HASU or a stroke unit, or you're a front door clinician, these are the important things to remind yourself to remember. So knowing exactly when the stroke started to happen in terms of symptoms. Their previous medical history will dictate what are their risk factors. Remember, stroke is a culmination of a pathophysiological process. Stroke mimics, I will talk about in next few slides. The functional status is very important, especially if you're considering mechanical thrombectomy. Current agreement with the National Stroke governing body is that should be offered to people who have reasonable functional status. So the mechanical thrombectomy is generally not offered if their modified ranking score is more than 2. NHS score is a tool to measure the severity of the stroke. As I said in the earlier slide, higher the score, more severe is the stroke. So this is the 1A4 sheet of NHS scoring points. There are 11 points to score. Maximum score is 41, and minimum score would be 0. So at times you will come across this dilemma where you'll be asking yourself, is it a stroke or is it a stroke mimic? So sometimes it can be difficult when it is a first presentation as compared to stereotypical recurrence of the presentation. But in majority of the cases, stroke is a cross-sectional event. It rarely progresses in a graduated fashion. Often it will happen like a lightning, and the symptoms will be worse at the onset. And then depending on the severity of the stroke, some patients will start showing spontaneous recovery. The ones who recover spontaneously within 24 hours, they then get classed as a TIA as compared to the ones who have persisting deficit. In majority of the cases, most TIAs will start showing improvement in a matter of few minutes, and a vast majority within the first hour of their presentation. If they didn't make a complete neurological recovery within the first hour, then in vast majority, they will have an identifiable ischemic stroke lesion in their brain scan, especially if you do an acute MR. Most strokes will have negative symptoms. Positive symptoms like pain, be it in the head, neck, and shoulders, or involuntary movements indicate a non-stroke pathology. And as I said in my earlier slide, loss of consciousness generally is not a feature of stroke unless you are coming across a posterior circulation event, especially basal artery occlusion, involving the midbrain circulation. Those patients will have compromised airway and impaired level of consciousness. So stroke mimics, S for stroke and S for stroke mimics, that's what the mnemonic I tend to suggest to my juniors. Whilst you need to be swift in your assessment and actions whilst dealing with acute ischemic stroke, you also need to be safe in terms of providing the interventions. So S for stroke and S for stroke mimics. First comes as seizures, be it partial seizures or patients with Totes paralysis. Syncope, where there's impaired level of consciousness. Sepsis, sugar, be it hypoglycemia or hypoglycemia. People with very low hypocalcemia or severe hypocalcemia can have focal neurological deficits. People with acute hyponatremia or hypernatremia can have focal neurological deficit. Patients with space-occupying lesions, patients with acute or chronic subdural hematomas. Sometimes in the elderly population, subdural hematomas doesn't need to have trauma. That can happen spontaneously. So acute neurological dysfunction always demands a acute brain imaging. Patients with substance misuse disorders like cannabinoids, symptomomimetics, they can come up with focal neurological dysfunction. Patients with spasms of arterial system, especially the migraines, causing impaired perfusion of the brain, leading to hemiplegic migraines, or patients with reversible constriction of the vascular system. And the last one is patients with functional weakness or psychological illnesses, patients who are malingering. Malingering is not as common as compared to the functional presentations. Having said that, functional symptoms tend to present in vast majority of medical clinics. For example, in gastroenterology, they present as irritable bowel syndromes. In gynecology, they present as chronic pelvic pain. In rheumatology, as fibromyalgia. In cardiology, as atypical or non-cardiac chest pains. In infectious disease department, as post-viral fatigue syndrome. With ENT as global syndrome. In neurology, as tension headaches or dissociative attacks. So 1 in 7 first fits tend to get classed as non-epileptic disorders. 50% patients presenting with status-like symptoms tend to come out as dissociative attacks. And apart from stroke, functional weakness can also come as patients reporting that I'm known to have MS and I've got further weakness to cope with. They all end up in the initial presentation going through series of investigations, and functional diagnosis is a diagnosis of exclusion. So we don't make a diagnosis of functional episode in their initial presentation. So in a observational analysis presented by John Stone, who is a pioneering authority in functional symptoms. He published this data quite some time ago, wherein they noted that headache was a common functional presentation in their clinics, closely followed by epileptiform disorders, peripheral neuropathy, multiple sclerosis, movement disorders, syncope, and stroke. So as you can see, stroke is not as common in their functional presentation as compared to other neurological presentations. In a study, majority of the functional weaknesses as stroke mimics, they came out to be secondary to post-syncopal recovery, underlying sepsis, especially urosepsis, patients with hemiplegic migraine, patients with functional motor weakness, and patients with epilepsy. In day-to-day practice, this is the most common 3 group of disorders: migraine patients, patients who have had focal epilepsy, and functional patients. So what are the helpful clues? So the presentation won't be pretty textbook straightforward, but you may notice that the gait is not typical hemiplegic gait. It's an unusual gait, sometimes an antalgic gait, sometimes a weird pattern in the gait. There will be inconsistency in their neurological weakness. So if you distract their right hand, which is completely dysfunctional, suddenly will show an unexpected activity, which will be unlike a paretic arm. Patients who complain a lot of pain at the onset, sometimes it's the pain which is restricting their limb movement, which then gets broadcasted as paralysis rather than pain-induced limitation of the limb movement. Labellar indifference, wherein your interaction with the patient indicates patient is not as worried as his symptoms are. And the Hoover sign, which I will show you in a minute in the slide. If that's positive, that's also a strong marker that the weakness is functional rather than organic. Older age patients tend to have less common presentation as functional weakness. Often we see it in younger age group, people in their 20s and 30s. Often the functional weakness patients have not many vascular risk factors. Being younger also reduces the list of risk factors in their medical history. Lack of objective findings, in the sense there will be variability in their description of symptoms, and a lot of description would be subjective symptoms rather than objective findings. And the other point is in the history, if they had had multiple previous episodes with major deficit, but their serial imagings have consistently showed normal findings. So that's a good evidence that you've tried to look for any objective pathology, but you haven't found one. Especially the patients with dissociative attacks tend to vary their history and presentation, and often they'll be visiting different hospitals. Sometimes it's good to know whether they have been to another hospital in recent times with similar presentation. Unlike stroke, often the evolution of the symptoms will be over minutes rather than sudden. Often patients will have a variable psychological manifestation in addition to their stroke presentation. Patients reporting dense arm and leg weakness may not have any cranial nerve involvement, which again should raise a suspicion whether it is an intracranial event or not. Often, if I don't see any cranial nerve involvement in their unilateral arm and leg weakness, then I tend to think about pathology below the skull, say cervical spine or cervicothoracic spine. If there's no head or eye deviation, which you will often see in major strokes, then that's also a pointer that pathology could be a non-stroke pathology. So in an observational study where they looked into 107 serial functional weakness patients, this is what they found. Lots of them had a panic attack. A lot of them complained pain at the onset, had dissociative symptoms at presentation. Symptoms came along gradually, and they had some evidence of physical injury to the limbs, i.e. complaining of pain more than the weakness, and the list goes on. So how to make a diagnosis of functional disorder? That will be based on their positive signs and familiar history in the past. You won't make that diagnosis just because the scan is abnormal, because in vast majority, you're only doing one modality scanning, i.e. CT brain scan. Often in the initial presentation, they will need a MRI head, and some patients might need MRI spine. So this is the Hoover sign, which is a very good sign to elicit to diagnose a functional weakness. It's based on that physiological function of anti-gravity and pro-gravity muscles. So our limbs work in pairs. So when I'm flexing my right elbow, then my left elbow tends to have involuntary extension to give that torque to that elbow flexion movement. So in this picture, the examiner is asking the patient to press on his palm through the right heel. And whilst the patient is pressing on his on hand through his right heels, he's trying to also ask the patient to flex his left hip. So normal physiological function should be that when you are flexing your left hip, you should have a pressure sensation onto your right hand. So if that's not happening, that means that right limb is not paralyzed. Does that make sense? Does everybody knows about the Hoover sign?
Please, can you explain that again?
So you place your palm at the base of the right heel, and you ask the patient to lift their left leg up with knee straight. Essentially, you're asking them to flex their hip. So as they're flexing their hip against the resistance, there should be, if the right leg is not paralyzed, then they will have an involuntary extension of the right hip, which you'll feel as a pressure in your palm, which is under the right heel. So that's the normal physiology. But if the right leg is truly paralyzed, then it won't have the hip extension. So you won't have any pressure feeling on your palm through the right heel. Whilst if patient is malingering or has got a functional right lower limb weakness, then you will feel the pressure in your hand through that right heel, whilst you're asking them to extend their left leg or flex their left hip against the resistance.
Thank you.
Make sense?
Yeah, thank you.
So that's a very good sign to elicit. It does require a bit of a practice, but once you have mastered the skill, that will be a helpful tool to identify the functional weakness patients. Remember, even then, you will still need their brain imaging, especially if it is their initial presentation. And this is what we're trying to preserve when we're trying to deal with acute ischemic stroke. So this is a circle of Willis, which is formed by the two internal carotid arteries and the two vertebral arteries, which join to form the basilar artery. And the system is connected with each other through the posterior communicating artery, which is a branch of internal carotid artery, joining the posterior cerebral artery. And anteriorly, the two anterior cerebral arteries, which are a branch of the internal carotid artery, are communicated with each other through the anterior communicating artery. So that's the circle of Willis, and that's what we try to preserve. Often the acute ischemic strokes will be in relation to these arterial territories being affected. This is a schematic presentation of the supply of the major intracranial arteries. So the yellow is supplied by the middle cerebral artery. Light blue, which is the medial frontal lobe, is supplied by the anterior cerebral artery. And the medial occipital lobe and the thalamus is supplied by the posterior cerebral artery. In vast majority of the cases, posterior cerebral artery is a branch of basilar artery, but we do come across anatomical variation. So roughly around 25% of the cases can have posterior cerebral artery as part of the posterior communicating artery, and basal artery just terminating into the superior cerebellar artery. So that's why in the medial occipital lobe infarct, we tend to rely on CT angiogram findings rather than carotid Dopplers to ascertain whether they are part of posterior circulation or the anterior circulation. In year to 2023, there has been a paradigm shift in the stroke guidelines, wherein stroke thrombolysis either with alteplase or tenecteplase has been recommended for patients presenting within 4.5 hours of their onset. To be able to thrombolyze, as the manufacturer has asked for blood pressure to be brought down to less than 185 by 110. The reason manufacturer has advised, because in their initial research, it was found that if we were to thrombolyze patients with uncontrolled hypertension, then the risk of intracranial bleed is significant. So we try to bring that down before we start the thrombolysis for vast majority of them. Always think of mechanical thrombectomy when you're using intravenous thrombolysis for acute ischemic stroke management. And always ask for a CT angiogram along with plain CT brain scan to give you a complete assessment of an acute ischemic stroke. Since 2023, the national guidelines have asked us to offer thrombolysis over extended period of time, which is beyond 4.5 hours, up till 9 hours, including the patients with wake-up stroke. But to be able to do that, we need to rely on more imaging support. So after 4.5 hours, to be able to do the systemic thrombolysis, we need to have an MRI scan, which needs to show us that there are positive DWI and negative flare images. And that will be the marker that this acute event has happened within preceding few hours. We can do the CT perfusion scan, and if we see a large mismatch, wherein the mismatch ratio is more than 1.2 and mismatch volume is greater than 10 ml, and the core infarct volume is less than 70 ml, then these patients can be offered thrombolysis. There's a talk about calculating the midpoint of the sleep as a surrogate time onset for people who have presented as a wake-up stroke. So you take the time when they went to bed, and then you take into account the time when they woke up with the symptoms, and you calculate the midpoint as a halfway point from going to bed to waking up with the stroke. Does that make sense? It's a good slide to keep the record of. So I'll show you another case. This is a 46-year-old man who was brought in by the ambulance, found confused in the town center at 4 o'clock. And you're seeing him at around 8 o'clock in the night. He's lying in the couch. He's drowsy but arousable. He's not verbalizing coherently. His GCS is E3, V2, and M5. Again, he has an HS of 9, and he's got a right facial droop. What would you do? As I said earlier, you will check his blood pressure, blood sugar, oxygen status, and then you will take him for a CT scan. This patient had a CT scan, which, as you can pick up, had a dense left middle cerebral artery, which is a marker of a long thrombus. As you can see, the length of the hyperdensity indicates the length of the thrombus. So this patient had a large thrombus. He was started with alteplase infusion, and then he was taken for thrombectomy. He underwent a successful thrombectomy and made an excellent recovery next day. So as I was mentioning, to be able to have a thrombectomy, one needs to have a functional modified Rankin score of less than 3. They need to have a moderately severe stroke, i.e. the NHS needs to be more than 5, and there needs to be a target to work on. Without a target, we can't locate a thrombus, and we can't do a mechanical thrombectomy. In vast majority of the cases, we should try to do the mechanical thrombectomy within the 6 hours of the onset, because that's where you get the most benefit. But since 2023, the thrombectomy timelines have been extended. So for acute anterior circulation stroke, which has presented to emergency department between 6 and 24 hours, in whom we have identified an intracranial internal carotid artery or proximal middle cerebral artery occlusion, who have an HS score of more than 5, and their pre-admission modified Rankin score is less than 2, they should be considered for mechanical thrombectomy, provided these criteria are met. So for between 6 and 12 hours, if their aspect score is more than 2, then even if they have a larger infarct, as long as there is a ischemic penumbra to save, we should be offering them a mechanical thrombectomy. For patients who have presented between 12 to 24 hours, who have an aspect score of more than 2, and CT and MRI perfusion mismatch is more than 15 ml, they should also be offered mechanical thrombectomy. Those of you who don't know what's aspect score, it is a scoring system to identify what is the size of a infarct burden. So the two slides, one at the basal ganglia level and another one is at the coronary data level. They are taken into account. So one at the basal ganglia, each color has got a score of 1. So you score 1 for infarct involving a caudate nucleus, 1 for internal capsule, 1 for lentiform nucleus, 1 for insula, and then 1 for frontal lobe, and the second for parietal lobe, and third for the occipital lobe. And at the coronary radiator region, again, you've got 3 points to score, 1 for the frontal, 1 from the parietal, and 1 for the parieto occipital lobe. So nowadays, the new softwares are automatically calculating the aspect score. So whilst you're reading the CT brain scan, you may see the aspect score automatically being generated through the AI. The modified ranking score, which I was talking about, people need to have less than 3 modified ranking score to be able to be eligible for mechanical thrombectomy. IV, our health system is not able to offer mechanical thrombectomy to all of them. It's a high cost, low volume service, and hence we have rationalized it to the group of patients who are reasonably functional to be able to get the benefit of mechanical thrombectomy. I think I'm running short of time. Any questions so far from me? So I've touched on the stroke mimics, and I've made you aware of most of the ischemic stroke guidelines. I'll skip through some of the slides to give you a bit of update on the rest of the stroke guidelines. So for posterior circulation ischemic stroke, there is an extended mechanical thrombectomy time, wherein if the onset is within 12 hours and an NIH score is more than 10, and they have favorable posterior circulation aspect score, then we should be offering the mechanical thrombectomy. There's not much research in mechanical thrombectomy for posterior circulation stroke in people who are more than 80-year-old. So we'll have to chase the patients case by case. So we'll still welcome the referrals, but be aware that not all of them will be offered mechanical thrombectomy in the extended time frame. This is a good slide we have made for everybody to be aware, where it gives you a flow chart at different time frames to offer the investigative workup. So 0 hours to 4.5 hours, not many questions asked. Between 4.5 hours to 6 hours and 6 hours to 9 hours, you'll have to rely on CT perfusion and MRI head scans. Between 9 hours to 12 hours and between 12 hours to 24 hours, all of them will need CT perfusion scan along with CT angiogram to be able to decide whether we can do a safe thrombectomy for them. Thrombolysis in practice, I think I will cover it at some other time. I just wanted to show you the TIA slide. So national guidelines on TIA management have changed since 2023. So the current guidelines recommend that for all TIAs and all minor ischemic strokes, as long as there is no significant concern for bleeding, offer them dual antiplatelet therapy. And now you have got option to choose from. So either you can give them clopidogrel and aspirin for first 21 days and then stop aspirin and let them continue with the clopidogrel. Those patients who are not able to take clopidogrel or aspirin, say, for example, they have allergy to it, or they have failed on clopidogrel therapy, i.e. they have further stroke whilst being on clopidogrel, then you can offer them ticagrelor. So Ticagrelor can be part of dual antiplatelet therapy with aspirin for first 30 days. And after that, you stop their aspirin and continue with ticagrelor. Clopidogrel has been a historic choice, but now we've got additional choice in the form of ticagrelor. Those who are not appropriate for DAPT, in them you will preferably offering them clopidogrel as a monotherapy. It's a good idea to give them a PPI cover, especially for the duration when you're giving them a dual antiplatelet therapy, especially the people who have a history of acid-rapid disease or gastroesophageal reflux disease. In patients who are having recurrent strokes while taking clopidogrel, do think about possible clopidogrel resistance if compliance is not an issue. And in those cases, you can switch them to the ticagrelor. We are working on getting a unified consensus on platelet impedance testing as a marker of clopidogrel resistance, but that hasn't come into the routine work. For patients who have AF and had ischemic strokes, the ones who had only had a TIA and they don't have any neurological deficit and have got normal imaging, we should start direct oral anticoagulant straight away rather than giving them aspirin in the beginning. For minor strokes who have got improving neurology, consider starting them on DOAC for day 5. There's an Optimist trial which is studying the option of starting DOAC at 48 hours in minor strokes. We'll share the results once they are available, hopefully by summer next year. For major strokes, for various reasons, most importantly, vast majority of major strokes tend to have dysphagia. So in them, giving the DOAC can be difficult. And also in major strokes, there's a risk of hemorrhagic transformation. So in them, we tend to delay the initiation of DOAC by 1 or 2 weeks. And we tend to rescan them to rule out hemorrhagic transformation before starting them on DOACs. Any questions?